Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 24, 2025. This video is on two articles, one published in Nature on 17 September 2025, titled Neuronal Architecture Underlying Autonomic Dysreflexia. The second article, published in Nature Medicine, also on 17 September 25, titled An Implantable System to Restore Hemodynamic Stability After Spinal Cord Injury. My own interest in this topic comes from the 8 months I spent at the spinal unit, the National Spinal Injury Center, taking care of tetraplegics and paraplegics at the Stoke Mandeville Hospital in Aylesbury, England. I had published a paper on the cardiovascular and hormonal responses to food ingestion in humans with spinal cord transection. It was published in Clinical Autonomic Research. Senior author was Professor C.J. Matthias. Autonomic dysreflexia and study methods. Autonomic dysreflexia is a life-threatening hypertensive response to stimuli, example bladder distension following spinal cord injury, especially above T6. It results from unregulated sympathetic outflow due to loss of descending control. The authors of this study used a multi-species approach, mice, rats, and 8 humans with spinal cord injuries. Duration, acute and chronic assessments up to 2 years. Sample size 1700 plus in the spinal cord injury patient survey. The interventional subset 8 humans. Techniques: single nucleus RNA sequencing, chemogenetics, optogenetics, viral tracing, and epidural electrical stimulation. Data analysis: multimodal statistics including transcriptomics clustering, neuronal mapping, clinical blood pressure monitoring, and autonomic dysreflexia symptom scoring. What did they find? In this Nature paper, they found they identified a maladaptive VSX2 spinal pathway as driver of autonomic dysreflexia. Colorectal distension activated lumbar thoracic VSX2 circuit resulted in activation of CHAT plus sympathetic neurons, and this was associated with increased blood pressure, p-value 0.001. The epidural stimulation, electrical stimulation at T12 to L2 reduced autonomic dysreflexia episodes and improved blood pressure control, p-value less than 0.005. Silencing VSX2 plus neurons reversed hypertensive response in animals. Limitations of the study: small human interventional cohort, long-term device tolerance and scaling remains untested. Key takeaways: first, identification of a defined spinal circuit for autonomic dysreflexia. Epidural electrical stimulation enables autonomic neuro rehab, reversing autonomic dysreflexia. Circuit-based therapies may transform spinal cord injury hypertension care. The next study is the Nature Medicine study, where they use an implantable system to stabilize blood pressure after spinal cord injury. Spinal cord injury, especially cervical or upper thoracic, often leads to autonomic dysreflexia, hypotension, bradycardia, and autonomic dysreflexia. Current therapies are inadequate and non-specific. This was an open-label, single-arm, first-in-human trial with the device STIMO-HEMO. 8 individuals with chronic spinal cord injury that is greater than 1 year post-injury were enrolled. Epidural electrical stimulation using a custom implantable neurostimulator targeting T11 to L1 spinal cord. Followed up for 2 years. Primary endpoints: systolic blood pressure stabilization, resolution of orthostatic hypotension and dysreflexia. The evaluation: tilt table test, 24-hour ambulatory blood pressure, neurocardiovascular mapping, and patient-reported outcomes. What did they find? All 8 patients showed significant systolic blood pressure improvement with 2 minutes of epidural electrical stimulation onset, p-value 0.001, less than 0.001. Resolution of orthostatic symptoms, improved autonomic scores, and suppression of autonomic dysreflexia. The effects were sustained during a 2-year follow-up without decline. Limitations: small sample size, just 8 individuals, no control arm, highly selective patient cohort, all with motor complete spinal cord injury. Scalability and insurance reimbursement is unknown. Key takeaway: first demonstration of chronic blood pressure stabilization using targeted spinal cord neurostimulation. Epidural electrical stimulation offers a rational, mechanistically grounded therapy for cardiovascular instability in spinal cord injury, a new frontier in autonomic neurorehabilitation, and implantable bioelectronics. Clinical pearl from these studies: in patients with chronic spinal cord injury, targeted epidural electrical stimulation at T11 to L1 can restore systolic blood pressure within 2 minutes, bypassing the need for pharmacologic vasopressors and offering real-time, programmable autonomic control. This represents a paradigm shift from systemic to circuit-specific therapy for cardiovascular instability in spinal cord injury. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom.